chop off the
cut that off.
the leg we don't need.
And then you will split it also this way.
Just cut off.
Mm-hmm. This way it goes on easier, right? So you don't have to worry about getting the other leg. Alright. So then we slide it. Perfect.
All right, so who gets to,
Who's gonna put it on?
who's putting it on?
Actually,
Yeah.
What do you want?
Bunch.
and then you can save this if you do.
You have to extend it.
Let's get extra material.
The same thing,
It is the
basically.
same thing, it's not a bad idea.
I don't know how you guys do it, but I try and like stick my arm up from the ankle and to grab the foot and like pull it down through.
Instead of pushing it down
And
through.
trying to push it down through. It does not, when it's broken, it doesn't push well, but you can definitely pull it and
Okay.
keep it there.
So, like this.
Oh,
So put this, I usually kind of get this one kind of started, because it just has to go through the big hole.
and then the
broken
other
leg.
like little
This is
thing
what you're
is that
saying,
usually
just
they
like
have
this.
a pulse ox. They usually have a wire attached to their unbroken toe, so you have to just ask permission to get that undone for a second to get the other leg through and then
This is what we
reconnect
did
their
in
pulse
Toledo.
ox. But those are all just like the little things that can be really annoying and like they waste 5 minutes of time while you figure out how to get like the pulse ox and stuff on. So, yeah. And I think that's good. So I think this is good, like just to see, this is sometimes what it looks like, right? Like their little pudgy leg. It's
Oh,
not
yeah,
like
yeah,
the
yeah.
knee like goes
Right.
right into this little thing.
So
And that's
sometimes that's
okay. Like you can maneuver a little bit if you need to. But I found that this actually, like it lays pretty flat, even if you have to roll over like that. And then I even put the
Towels in.
towels in too.
Now, do you want them like
Yeah.
skinny like this, or do you want anything to be wide? Like
I don't make it super wide.
I think
but
that's about
this
as wide
is-
as the blue
that's
towel, so
about
I,
as-
that,
yeah.
I think that looks pretty
What is
good.
that, about like 4 towels?
I usually
So
use about
that's,
3 or
I
4.
guess,
Four,
whatever.
okay.
If you just ask for like a pack of
Okay.
blue towels, it usually comes in a stack that's about this thick.
Okay, so that,
to
okay.
set, okay.
But, or you can do something like this, but I mean, even on a bigger kid, I might make it a little bit bigger.
Okay. And then,
So then some people will, they'll count, you'll lift the patient, some people move the bed underneath. And so then this has to go.
and then this is another one, can you guys all see this? This is one of the other crucial points right here is that when you lay the patient on here, their crotch is gonna be right up against where this post goes,
And then
but you
the-
have to make sure the underneath post goes inside the lining so you don't wrap it into the cast.
So this is.
Okay.
And then here's the post.
Then you'll put- And then you can pull the patient down. And then there's usually arm boards too, I guess.
See, we didn't have
They can also,
such a mess.
So we only have the arm boards if we're in the OR?
Yeah.
So for the ED or clinic, we
Somebody's
just have.
holding them.
this is also an easy job for like the nurse who's doing sedation, like this doesn't require any like repositioning, so if they can just hold the arms and also do their nursing job, just holding them out of the way of the wrapping is okay too.
And so then somebody like your
Do we-
resident will be holding the leg, all right, or the fellow, whoever's there. And then, this other leg will be supported by like anybody, doesn't really matter. And then the good thing about this liner is you don't have to wrap any web roll. You just put the fiberglass directly onto it and you wrap it like you would a regular cast. And so after you get it wrapped around once, then I usually will roll up all the edges and then like lock it all in. When you're doing a single leg spica, you only have to really worry about one end-turn triangle. You don't have to worry about the other one. So there's only one.
How high do you want it to be when it's just the pelvic, or we don't want a pelvic band, or how?
I still make like a regular like belly band.
You want
I
all
don't
the way,
know.
cause
I just
we
go
were-
like right
we
inferior
were
to
low,
the-
how tall he
how low
was.
it goes?
Yeah, like.
Yeah, like right,
I just go like right below the belly
Okay.
button.
yeah,
So
all the way probably up to
wrap,
here.
okay,
Yeah.
and then
Yes.
Fiberglass to there, and then down kind of to the ankle, and then I usually have them put their hands inside, like down here, so that it doesn't get too tight around the ankle, because I think that was one of the other issues with the other cast, was that it was really tight around the ankle. So if you keep your fingers in here underneath like the Achilles when you're holding it, then it won't get too tight. There's like extra space automatically there.
Sometimes, as you know, like when we're in the OR with other providers, they'll put like some foam under there. So
Okay.
sometimes
Another way.
even just like, if you don't have an extra hand to really be holding that, sometimes I'll take like a wad web roll. Because when you flip that up, you can slide that out, and that just gives that little barrier. So we don't always have foam at our disposal, and most people would like it up a little bit higher, not quite to the nipple line. Obviously, because a lot of times we don't have enough length in these liners, but usually giving it just enough structure so it's sturdy enough when the kiddo's moving around.
Yeah, and I think that the reason that I don't take it too high on the belly is that we're trying to make this, like, you
Easier.
don't need to
Quick.
trim anything.
Yes.
And so, if it's only like a true pelvic band and it's not like a spica up to the nipple line, then you don't have to trim out like something for the belly.
Yeah.
You don't have to trim out the top. It literally is just a band. It just has to be big enough to anchor this on and to be able to anchor your like intern
back.
triangle like struts in the back. And then the other couple of points just that sometimes you don't think of till the moment are where this part ends. You don't want the bottom part of this to be anywhere where you're going to be wrapping, right? So that if this patient was too high up on here and this was like hitting right here, it would get in the way of where you're wrapping. So usually if the end of if you know their chest is low enough here that their like their armpits are kind of at the bottom of here, you'll have plenty of room to wrap and fold down and not have to worry about this table getting in the way. And just, I don't know if you guys have all used the spica table a lot, but this, if you unlock this, that can give you, it's a real tall patient, you can slide everything down so that all this is still free, regardless of the height of the patient. And then just make sure that that's locked up before you start wrapping so that this part doesn't come loose. And then I think just one more other like positioning point. You can see that without like saying it, Dr. Romuling's holding this in the position that we wanted, and we want it to be in a good sitting position, so close to like 80 or 90 degrees of flexion at the hip and at the knee. And you can imagine that allows the patient to like sit in their car seat, sit in a chair, not be straight out and be able to not sit safely in a car seat at all. And it also, for any fracture that's in the mid shaft or the proximal femur, by bending the hip, you're actually bringing this broken part up to meet this one. It's hard to control, like through all the muscle, like pushing a fracture into place. So if you try and put a cast on with the leg straight, the fracture is going to want to like point up like this. But by bringing this part up to it, you have to do less work to get the fracture lined up. So flexion at the hip, flexion at the knee, and obviously you want to be able to put a diaper on, so you don't want it straight ahead. You want it out to the side just a little bit, like what she's doing. And then I think the easiest thing with the well leg is to just hold it the same, because it's hard to hold one way versus the other.
And then you also, when you're wrapping, you want to make sure that that other leg
Yes.
can kind of flex out. And so on this side, I usually try to make sure that there's like room for them to come up so they can sit, so you don't end up too low over here.
And exactly, so by holding it in this same position on that side, in flexion, so you don't wrap too low where it's impinging on the top part of their thigh. And I would say that probably no less than 10 or 15 times when I'm there doing a spica, I have to tell the person holding the leg, like,
Flex it.
bend it, don't let it extend.
Because when you're wrapping,
Flex
it
it.
tends to like want to like
Yes.
extend. So like as you're like putting pressure on it, like during the wrapping process, and then also just with gravity, it wants to fall. So you have to remember to keep doing that.
And it's important to wrap all the way down the leg in several layers so that you can get a good
Mold.
Yeah,
Right.
and not just 2 layers down to here and then try to mold it and then,
Right.
so,
Wrap the whole,
Right.
you have plenty of time
yeah.
Yes.
to wrap everything first and then
And
do your
honestly, mold is important, but it's not that important.
mold. Right, if you're
because-
doing this, if you're holding it in this position, the fracture's gonna be reduced,
Yeah.
and the mold just helps keep it
And
there.
then-
If you're doing this, the mold becomes more important because you're fighting all the muscles in the leg. I'd say that so many times in fast clinic, people come back and their spica is like straight out, and I'm like,
I just always ask when the resident is, or resident fellow, whoever's holding,
Yeah.
before I start wrapping, I say, is this the position you want them in? And I
Yes.
say it several times when I'm wrapping, is this the position? Because I see it
Yeah.
changing, they slowly relaxing. Is this the position you want it in?
Right.
Then they correct themselves.
yeah.
So
Yeah,
make
no,
sure,
that's
because
good.
I just keep
That-
asking
as long as
them.
they know the right position. I
Yes,
think that's the
correct,
problem,
yes.
is that sometimes they don't,
Yes.
they're not confident in that. And you're
Yes.
asking the right question, but they're like,
Yeah, and I know the
I'm
position,
hedging.
like I know the position, and I know it's not straight.
Yeah.
So anything bent is better than straight like that.
Yes.
So,
Yes. So seated position,
Mm-hmm.
flex, flex. Okay, cool. That's my.
Do you
Start wrapping?
want me to
Do you
hold
want us to
something?
both do it? Do you want me to start wrapping at the top and Dan, or do we wanna just do it
Yeah,
all
do you-
one? What do we wanna do? 2 of us or 1?
Let's do one at a time, just because I think in the ED setting, we usually don't have the luxury of having 2 people
Okay.
wrapping at once. So let's do it realistic.
Okay. Do you want me to hold anything, Dr. Hemlingham, or are you good?
Okay.
Okay.
I'll let you know if I get tired.
Sure.
I know the patient's really happy.
Super heavy.
How's your thumb?
Swollen.
Is it?
Can you just, as where you want Danny to wrap, can you
Yes.
just kind of talk her through that area and where she should go for guidance for
Sure.
kind of learning on our video, please?
I think starting with locking in the belt there is probably a good place to start. So Danny's leaving plenty of room at the top to be able to fold back down, and I think that's a perfect height for the band there. It doesn't need to be any higher than that. That gives them plenty of room to eat. And I think her tension that she's using is good. She's not like constricting the belly. She's not like, you can tell that it's staying the same shape. It's not like turning into like an hourglass where she's wrapping. It's not getting more constricted.
Danny, do you want a 3 or 2?
Maybe a 2.
Perfect. And so the belly band, you want it to be thicker, like a 3-inch or a 4-inch, depending on the size of the patient. You can see that Dr. Romalingham is flexing the other leg to make sure that that's not going to impinge on the bottom part there.
And now you can probably start to lock it in and start going down the leg a little bit, so.
And you can see she's doing this nice figure of 8 type maneuver where she started on the belly band and is wrapping then around the most proximal part of the femur there, going around to make a cuff there, and then she'll kind of come down the leg, and then we'll come back and do a few more like figure of 8s to lock that into. And we're keeping good flexion at the hip there, keeping good flexion at the knee. We've got some abduction so that you're able to like diaper or toilet. And then
down
we're
here
stopping this
too.
one above the malleoli. I don't
Yep.
think this patient has malleoli, but she's very not tightly wrapping several layers there around the non-existent malleoli.
My
leaving
fingers are
plenty.
still underneath it too.
Yep.
on the
Dr.
side.
Romalingham is the malleoli there.
Yeah.
And you can see she's doing some fan folds at the knee so that the patient can't extend their knee. And then coming all the way back up
Do
to
we
the
wanna,
thigh. Let's do one more 2-inch
one
to,
more?
yeah,
Okay.
because I think right
Yeah.
now it's still a little too floppy at the hip there before we start doing any kind of a mold. But you can see this is all still very malleable. There's still plenty of time to mold. She's putting some extra right at the thigh there because that's where our hands will be for the mold, so that gives it some good structure.
And you can go up, do a couple figure of 8s around the top.
Perfect. And that's awesome. She's doing these figure of 8s to make sure we have a good connection between the belly band and the leg part. And on a patient whose leg is this skinny, it folds a little bit there. On a chunky thigh, thigh is thicker at the top than it is
It's
at the
not gonna
bottom.
fold
It's
like
not
that.
like a stick like this. So this is harder on
And then
the
the oth-
doll than on the real patient.
And then now you can start to fold everything up, and then, well, first we'll do like a slat.
Yep, and
a
Lisa
slat.
has slats for covering. You want to actually somebody should actually look underneath here. You can see
Where
that there's a triangle
Do you
where
wanna
there's not
see a
any
picture of that
structure.
with your camera?
Here,
Come over here.
I'll take it for just a
Pull
second.
that off close for a second.
Okay, so here in the back, you can see where it comes to a point and there's missing structure right there. Okay, and then fold. Perfect. So you can see this, this reinforcing layer is both on the front and the back at that same juncture point, anchoring it, and now being anchored in place by a roll. Okay, thanks.
And that's the same thing you do on a double leg spica to reinforce it as well, but
Exactly. And then I think at this point,
we can
we
start to
said,
fold everything
we can
up.
fold everything up,
And then we'll usually cut some of this out if there's too much. I just usually like to
make it
wait
one.
and see how much we need for the size of the patient.
Yep.
But you fold all the edges up.
And then I think now, if you're starting to feel like it's getting really it's starting to set up. You can do the mold here before you do this locking in, because this is all going to be the finishing at the end. So with the hip still in flexion and the knee still in flexion, Dr. Rummelingham is molding it like with the whole like flat part of her hand into valgus, so pushing from the outside, pushing out at the knee,
Do it a little bit
and then
from the
putting a mold on the front part of the thigh there. Because the way that a femur fracture wants to displace is with the point going toward the front of the thigh or sagging to the outside of the thigh. And so those molds keep it, as the swelling goes down, it keeps it from falling out of place. And now everything's been folded back. And Danny is wrapping, leaving a nice cuff at the top of soft material. You're leaving the towels in until the very end too. Don't take those out too early because you
Little
still
high
can.
roll.
Good. Good. And that's the help of the teamwork, is somebody telling you the parts you can't see.
You look good.
Hi. Oh, no, thank you.
Probably just one more 2-inch. Oh, you have it.
Yeah.
And then this is the part that can be a little bit tricky, to make sure you lock all these things in, make sure that everything's pulled back. If you need an extra set of hands to kind of help pull some tension
yeah.
on things so that it actually gets locked in with the fiberglass.
A little higher, baby. Thank you.
Good. And you can see if there's anything that looks like it's under tension or it's pulling away from the creases there, she's just making little relaxing cuts with the scissors so that everything lays flat.
Maybe.
Right here.
Yeah.
And I think if you can capture that.
Right here.
Yep. Sometimes I'll even, like, on this last layer, sometimes I'll even bring it, like, I know you're supposed to go around the leg, but I'll bring it down like that and, like, kind of go the wrong way around the...
Back over this way or back?
Just-
Yeah.
Good.
Oh, you're going around again. Sorry. Perfect. Yeah.
And I can
And then the same thing, we would
Just
use
lock
some
that
to,
in.
like, lock in at the end there. It probably,
We
I
don't
don't
need
have to
to
do that
do
for
it.
this.
Don't want to.
But then you can see at this point now, this leg can still flex up. There's not anything where it's impinging on that side. This part over here is good. There's been a mold put here and here.
Everything's
The hips
locked
still
in.
flex, the knees still flex. This will sit well. And at this point, you can usually take the patient off of
Mhm.
this table and then take out the towels.
Because we'll have to get some x-rays too, and it's
Yep.
usually easier to get them off of this leg.
Exactly. Good, and then I think, why don't we do that? Why don't we take them off just to make sure that we show like what not to leave behind? If you
Yeah.
put anything down at the ankle,
Take
and
that
then
out.
as you take this off, we can take the crotch post off. And then remember that these things underneath them are inside the cast, and they sometimes leave web roll behind. So you've unlocked that part of the bed, and you can actually pull the bottom part out theoretically. Yep, there you go. And then you have to pull the patient down off of that post and then lift them up. You got that, Tara?
Yes.
Okay. And see how that's bare now? There's no web roll left on
Because it's
the
right
thing,
here.
because there's something left in the back of the cast, so you take that.
And so now you can see that this patient has a lot of room in their belly for when they sit up. And room for their legs.
Show what it looks like in the back.
And then there's
There's nothing to trim in the back
There's
there,
nothing to
because
trim.
Their butt crack should be visible.
and there should be space for diapering still.
And then for diapering, I usually, if you can't tuck a whole diaper underneath here, I usually put a big maxi pad, like right inside, so you can tuck it front and back, and then put a diaper over top of everything. So I feel like that's one of the main questions they ask about young patients.
And then if you have any issues with the edges, you can still put high tape on them.
When it's nice with this cast too, with the diapering factor, that they can get it wet. So if there's soil or urine or something, they are able to wash it off.
And this patient can sit.
Yeah.